Academics Office by Jana.
Thank you. You can imagine that as a medical student, I have few financial disclosures except for bank loans, but Dr. Donahue does, and they are listed here. Amblyopia remains the most common cause of monocular vision loss in children and young adults. Efforts to detect amblyopia risk factors and initiate timely treatment are widely viewed as integral to pediatric primary care. The prevalence of amblyopia risk factors in the pediatric population is estimated to be approximately 15 to 20%, with evidence that there is a direct relationship between a child's age and the depth of amblyopia in the absence of appropriate treatment. There is also a known inverse relationship between age and the effectiveness of amblyopia treatment. Therefore, the detection of amblyopia risk factors and early initiation of therapy are imperative for helping to prevent future visual complications. Since the first automated devices for preschool vision screening became commercially available approximately 2 decades ago, photo screening instruments have undergone a transformation in regards to their ease of use, while remaining highly effective in detecting amblyopia risk factors. Photo screeners offer several potential advantages over traditional methods, including requiring a shorter time to screen per child and less patient cooperation per screen. In recent position statements, the United States Preventative Services Task Force and the American Academy of Pediatrics both recommended automated vision screening as a valid tool in the pediatric population. Automated screening instruments have undergone extensive validation in pediatric ophthalmology clinics and in the field. However, validation in the medical home is lacking. The purpose of this study is to describe the first large-scale, multi-center evaluation of commercially available photo screening devices in the medical home. This study involved 11 pediatric practices from 7 different groups in Middle Tennessee. They recruited 3,100 participants aged 12 months to 5 years who were presenting for well-child exams. After consent was obtained, participants were screened using the Spot Vision Screener. Children who were referred by Spot received a gold standard exam with cycloplegic retinoscopy. Gold standard for the eye exam were the 2013 amblyopia risk factor criteria, which are published in the Journal of APOS and shown here. Note that they are age-based and of higher magnitude than the 2003 criteria. Results are shown in the next few slides. Here is a pie graph demonstrating the relative distribution of the number of children screened per practice. We restricted recruitment so that no one practice screened more than 16% of the total study population. Referral rate by practice is shown in this table. Our overall referral rate was 10%, which was fairly consistent across all practices. The only outlier was Southern Hills, which is located in a predominantly Hispanic population, which, as you know, has a higher prevalence of astigmatism. Primary reasons for referral are shown in this table. As you can see, the majority were referred for suspected astigmatism. A large number were referred for suspected anisometropia or strabismus, while the numbers referred for suspected hypermetropia, myopia, anisocoria, or media opacity were all low. Gold standard for determining whether the eye exam was positive or negative for amblyopia risk factors were the 2013 guidelines published by the Vision Screening Committee of APOS. As you can see, suspected hypermetropia and myopia had high positive predictive values, while suspected astigmatism and anisometropia had moderate positive predictive values. The positive predictive value for suspected strabismus was 33%, further supporting previous studies that highlight the need for redefining the current algorithm used to detect strabismus. The positive predictive value for suspected anisocoria was 0% because the only child referred for this reason had a normal follow-up exam. Because the 2013 guidelines are more stringent and require higher levels of refractive error, we reevaluated the data using the 2003 guidelines so that these data could be compared to previously published field studies. According to the 2003 guidelines, our overall positive predictive value was 61%. Referrals for suspected hypermetropia, anisometropia, astigmatism, and myopia all resulted in high positive predictive values. The positive predictive values for suspected strabismus and anisocoria remained unchanged. In an attempt to determine sensitivity, we examined a subset of children who had normal screening exams. Approximately 300 were contacted, 75 scheduled, but only 12 showed for this follow-up exam. All 12 children examined had no amblyopia risk factors, which further supports the results of our study. However, this number is not robust enough to get a good handle on sensitivity and specificity. This has been the most significant limitation of our study, and we are disappointed at how difficult it has been to get these normal children back to clinic. Results of this study conclusively demonstrate the effectiveness of automated vision screening when performed in the pediatrics office. More than 50% of children referred had amblyopia risk factors detected, and 14% had amblyopia. This is substantially more than in the general population, which is thought to be 10 to 15% for amblyopia risk factors and 1 to 2% for amblyopia. The United States Preventative Services Task Force and the American Academy of Pediatrics both endorse automated vision screening in the 3 to 5-year-old population. The USPSTF gives an I rating for screening in the 1 to 2-year age range because they felt that the data were inconclusive. This study provides prospective evidence that photo screening can be used just as effectively in this younger age range, which should make this inconclusive rating obsolete. In conclusion, this multi-center prospective trial of photo screening in the pediatrics office supports previously published studies from the field and will hopefully help increase acceptance of this technology among our pediatric colleagues. Thank you.
I'd like to invite all the presenters